Hello and welcome to this presentation lecture, and you are going to know about muscular dystrophy for MBBS and BDS. Now first of all, classification and description for muscular dystrophies. Muscular dystrophy includes Duchenne and Becker dystrophy, which is X-linked inheritance, limb-girdle dystrophy, which is autosomal recessive inheritance, facioscapulohumeral and oculopharyngeal dystrophy, which is autosomal dominant inheritance. Among these, the most common type have been described below: Duchenne muscular dystrophy or DMD. DMD is most severe and most common type, X-linked inheritance, and females are carrier and males are symptomatic. Presents with progressive muscle weakness and wasting, which manifests by 5 years of age. Paralysis and death by second to third decades. It means second decades 10 to 20 years to third decades 21 to 20 to 30 years. Weakness begins in the pelvic girdle muscles and then shoulder regions is affected. DMD is characterized by a positive goer maneuver syndrome, in which upper extremities are used for stand up, and pseudo hypertrophy, which is represented by the enlargement of calf muscle with weakness, may affect cardiac muscle resulting in arrhythmias and heart failure, may be associated with intellectual impairment. Death results from respiratory insufficiency, pulmonary infection, and cardiac failure. The cause of death are respiratory insufficiency due to the weakness of respiratory muscle, and pulmonary infection and cardiac failure. Now pathogenesis. Now the pathogenesis: abnormalities in the gene encoding dystrophin located in the XP21 region. The P21 region of the X chromosome encodes dystrophin protein. Dystrophin is the protein, and this abnormality is caused by either deletion or point mutation. Dystrophin and dystrophin associated protein complex anchors actin to membrane glycoprotein. Absence of dystrophin causes transfer of the force of contraction to connective tissue and myocyte degeneration. Now second one is Becker muscular dystrophy, also called BMD in short form, which is less common and less severe. BMD patients have mutations in dystrophin gene resulting in decreased amount of dystrophin, usually of abnormal molecular weight. In BMD, the dystrophin is either reduced or it will have abnormal molecular weight. But in DMD, the dystrophin is absent. Now morphology of the dystrophic muscles. Most histopathological abnormalities are common to DMD and BMD and include variation in fiber size, presence of both small and large fiber with fiber splitting, increased number of internalized nuclei, normally less than 3% are internalized, degeneration, necrosis and phagocytosis of muscle fibers, regeneration of muscle fibers and proliferation of endomysial connective tissue. DMD cases also show enlarged rounded hyaline fibers with loss of cross striations, hypercontracted fibers, a finding rare in BMD. Now, laboratory findings. Antenatal diagnosis of dystrophin defect using recombinant DNA technology. Serum creatinine kinase levels decline as muscle tissue is progressively replaced by fat and fibrous tissue.